Good morning. This is Dr. McDaniel. I'm a board-certified obstetrician gynecologist in New York City, and I'm bringing to you all things health-related for women. Thank you for joining GYN Corner, and today is the third part on pelvic organ prolapse, or POP. So previously I discussed the definition and the evaluation compartmentalization for pelvic organ prolapse. So I'll give a brief review now, but you can go to yesterday's and the day before's presentations for that, please, for the details. So pelvic organ prolapse is prolapse or herniation or collapsing of the pelvic organs. And the pelvic organs are the bladder in the front or anterior component, the uterus and cervix in the middle, that's the mid compartment, and in the posterior compartment or in the back is the rectum, and associated with that are the intestines, the small intestines. So the pelvic organ prolapse is referring to the collapsing of one or more of those pelvic organs, or three areas of the pelvis collapsing or falling through the pelvis and out of the body. I started with the anterior compartment, which is the bladder, and the associated urethra yesterday. So the bladder, when it falls out or herniates below the pelvic muscles, that's called a cystocele. And as it falls out, it bulges into the front of the vaginal wall. So we call that an anterior cystocele, because it's the anterior portion or the front portion of the vaginal wall that the bladder starts to bulge or herniate through. One can have mild, moderate, or severe prolapsing or herniation. Severe, or a fourth degree as it's sometimes called, is bulge or herniation of the bladder that's completely coming out of the vagina. The person can stand, open their legs, and there's a bulge falling out, crowning out through the vaginal lips or the labia. That's a fourth degree cystocele. And third degree is when it's just reaching at the vaginal opening, but you can't see it coming out. Second degree is as it's bulging into the vaginal canal, but it's not reaching towards the opening. And a first degree or mild cystocele is just a mild bulge, and that's with stress. So any kind of stress, either severe or moderate over time, stress or pressure is what causes a herniation of the pelvic organs. And as I listed previously, the most common ones are going to be frequent coughing, frequent heavy lifting of 25 pounds or more, or pulling or pushing, obesity, 30 pounds or heavier, especially if it's abdominal weight. Puts a lot of stress and pressure over time on the abdomen and on the pelvis. Definitely pregnancy, because that's a lot of abdominal weight, and then vaginal delivery, because there's a lot of stress and pressure pushing on the pelvic floor to deliver the baby, and then the baby's head is stretching or compromising the pelvic floor muscles. Sorry, frog in my throat today. And then any cofactors to that would be things that compromise the pelvic muscles as far as their integrity or their elasticity and strength go. Smoking is always a compromising factor because it compromises the blood vessels or vasculature, and that can decrease the oxygenation and flow of the hormones that help support the pelvic muscles. And then menopause, because with menopause, the estrogen that helps strengthen and keep the elasticity of the pelvic muscles is diminished. So those are some of the risk factors for increasing prolapse or herniation or collapsing of the pelvic organs. And the anterior pelvic organ is the bladder. So the cystocele or the anterior cystocele, the collapsing of the bladder, is one of the first most common herniations or prolapses. The woman who is experiencing that may just simply experience a lot of urinary issues. So with coughing, sneezing, running, jumping, standing, or any kind of increased abdominal pressure, she'll have loss of urine initially because the pelvic floor muscle, which helps maintain the strength of the sphincter. I'm sorry, one moment. Excuse me, I felt that sneeze coming on, sorry. The pelvic floor does not maintain its strength or integrity with any increased abdominal pelvic pressure, and she experiences loss of urine due to the weakening of the pelvic muscles. As the bladder starts to really fall into the vaginal vault or vaginal canal, she'll start to have along with loss of urine, or what we call genuine stress incontinence or stress incontinence, she will also start to have a backlog of urine, because that herniation into the vaginal vault creates a pouch or a little pocket where the urine can collect and then not effectively be eliminated when she goes to urinate. So that will create stagnant urine, and stagnant urine is literally and figuratively a cesspool for bacteria to build up and then have frequent bladder infections, cystitis, UTIs. In addition to that, she may notice that after she urinates, when she stands up to put her clothes back on, she'll start to have a little bit of a leakage, involuntary leakage, or dribbling of urine, and that's because some of that pocket of urine that's collected in the herniation or the cystocele will start to pull out with the change in the positioning. So she'll have some post-urinary leakage. So those are all signs and symptoms of a herniation or a prolapse, a collapsing of the bladder muscle, which we call, again, an anterior cystocele. The evaluation for that is pretty simple. We do a physical exam to see if there's herniation with or without stress or pressure, and then sometimes, depending on the patient's symptoms and the evaluation, she'll need cystometrics, which is a measuring test of the bladder's capacity to fill, empty, and then different strains and stressors which cause urinary loss. Treatment for a cystocele, depending on the severity of it, the first type of treatment will be, if she's menopausal, to give her estrogen, vaginal estrogen, to help bulk up or plump up or increase the integrity of the pelvic muscles and of the vaginal tissues. And then in addition to that will be either Kegel's exercises, which are kind of so-so. Kegel's exercises are tightening, voluntary tightening of the pelvic floor muscles. And you can think of, if you have, say, you have to urinate and you want to hold your urine, you tighten those pelvic muscles. Or if you have to have a bowel movement, you tighten those pelvic muscles so you don't have bowel movement or urinate in an inappropriate place. So it's Kegel's exercises are tightening of those pelvic muscles frequently and for a fairly long time, 30 to 60 seconds. What works better than just someone doing Kegel exercises is biofeedback or physical therapy, where you see a physiatrist or a physical therapist, and they will do some muscle exercises where you respond to different stimulation, or they'll have little machine that gives stimulation and helps direct the tightening and the length of tightening. So I can take that from you. So the estrogen supplementation, the vaginal estrogen, biofeedback, physical therapy, Kegel's exercises, those are all kind of first line treatments. Second line treatment is a pessary. And a pessary is a silicone or a rubber plastic device that is shoved or pushed into the vagina, kind of like a tampon would be, to push the bladder back up into its normal position in the pelvis and to push that herniation back up so that you don't have that extra pocket of urine. There are a zillion types of pessaries. Some of the pessaries look like donuts, others look like boxes, others look like little dumbbells. There are a few that are specifically shaped or formed to help support the urethra or the neck of the bladder so that it sits up high and it decreases the stress incontinence or incontinence with increased abdominal pelvic pressure. A pessary has to be fitted by a gynecologist, and then the patient has to learn how to put the pessary in and how to remove it, and it should be removed at night so that she has rest and decreased pressure on all those tissues during the night, and it should be cleaned off at least 2 to 3 times a week. I used to give patients a tube of kind of a cream or an ointment antibiotic to place on it so that it decreases bacterial buildup and decreases odor that can build up from the bacteria. Lastly, for severe cystocele or severe herniation of the bladder is going to be surgery. And the most common surgery is called an anterior colporrhaphy, which is a tightening of the pelvic floor muscles underneath the bladder to support and push that bladder wall up and out of the vaginal vault. And sometimes it's a sling, which is increased support and tightening of the muscles and sometimes using foreign objects to pull the neck of the bladder up the urethra to decrease stress incontinence once that herniation or the prolapse has been treated. Now, several years back, a lot of companies were pushing, and GYN surgeons were using mesh products. The mesh products have fallen out of favor because they've had issues with erosion, so the mesh rubbing with the friction and creating a hole, a herniation, an ulceration into the vaginal and into the bladder tissues. So the meshes have fallen out of favor. We're back to just plicating or sewing up the pelvic muscles and using older non-pelvic muscles or older foreign objects or tissues to help support the neck of the bladder. So the treatments are estrogen, Kegels exercises, biofeedback, physical therapy, pessaries, and last but not least, surgery. So I hope that's been helpful information on pelvic organ prolapse, the anterior component or anterior compartment component, which is the bladder, and the associated urethra, which is called a cystocele. Thank you for joining me. This is Dr. McDaniel, board certified OBGYN in New York City. If you're in the tri-state area, come on by. We're in Midtown Manhattan, and the office website is midtowngyn.com. Please check out the YouTube channel, that's GYN Corner, and our podcast platforms, GYN Corner, and subscribe or follow so you can get a heads up on the presentations and what's being presented. Thanks again. Have a great rest of your Wednesday. It's hump day. See you tomorrow. Bye.